Hello and welcome everyone to the part 3 of Rapid Fire Pharma Review. In this video, we are going to cover DNA synthesis inhibitors, which are basically antimicrobials. And once you master these DNA synthesis inhibitors, you will be able to answer questions related to these in your step examination confidently greater than 80% of the times. So if you like this content, please like, share, subscribe and follow for more. So let's begin. So if you remember from our part 1 and part 2 of our rapid fire reviews, those are the ones in which we were basically focusing on the cell wall. So the agents or the drugs that were basically acting on the cell wall and causing the inhibition or disruption of the cell wall synthesis. But in this one, the part 3, we are basically focusing on the DNA synthesis. So all the drugs that we are going to study here will come together and they will basically form the drugs that are responsible for inhibition of the DNA synthesis. And what we are going to do is that we are going to take a slightly different approach, and I just want to introduce that approach beforehand, that the way that we are going through these drugs one by one is that we will begin from the clinical presentation, which is the way in which the questions are framed in your NBMEs along with your step examination, is that the patient comes to with certain complaints, then we backtrack from the presentation. So we know that this is the presentation, this is the disease that the patient has. From it, we have to trace it back and connect it. Okay, if this was the presentation, then what is the drug that was used? And then what was the drug's mechanism of action? And similarly, along with the presentation, we'll go ahead that, okay, this was the presentation, this drug was given, and this was the adverse effect that developed. So because this was the adverse effect that was developed, so which was the drug that was used or which was the mechanism of action? So from the presentation or the adverse effect that was developed in the patient, we have to trace it back and then we have to go and find out the drug and the mechanism of action. So this is how we are going to go through all of these drugs today as well, right? So suppose you have a drug that you are basically using for as a last resort for a multi-drug resistant gram-negative organism such as Pseudomonas, right? So you have this patient who is admitted to the ICU and now he has developed this multi-drug resistant gram-negative Pseudomonas infection, right? So what is the hard-hitting agent that you are going to use? Obviously, you know that vancomycin is your hard-hitting drug. Vancomycin, carbapenems, as well as the aztreonam we studied last time, they were a hard-hitting agents. Of course, they cover Pseudomonas as well. But if it has multi-drug resistance and they say that it's resistant to vancomycin, it's resistant to aztreonam, it's resistant to carbapenems, what other option, a hard-hitting drug do you have? So then you're going to trace it back to the hard-hitting drug. The name of the drug is basically Polymyxin and specific name for the drug is colistin, right? And then they can ask you about the mechanism of action. Then the mechanism of action of this drug, this hard-hitting drug for the multi-drug resistant gram-negative Pseudomonas, is basically it has a cationic polypeptide tail that acts as a detergent on the cell membrane. So basically it changes the surface tension or acts as a surfactant on the cell membrane. So because of that, it causes the leakage of the cellular component cell death and causes cell death. So either they can ask you reverse by asking you the clinical presentation that what is the mechanism of action, or they can say that what is a drug that acts similar to this mechanism of action, any drug that causes the leakage of the cellular component. So we're also going to do these integrations along the way, that which other drug has a similar mechanism of action to this. So then that would be amphotericin B. Of course, it is slightly different, that it basically creates pore in the cell membrane, but after creating pores, the main mechanism is the same, that causes the leakage of cellular components and death. And another one that we're going to study today, daptomycin, it's also very similar, but it alters the charge barrier, and by altering the charge barrier, ultimately it causes the leakage of cellular components. But the main thing, if you were to be asked that which 3 drugs basically cause the leakage of cellular components, so that would be the polymyxins such as colistin along with amphotericin B and daptomycin. And what makes these all 3 unique? Remember, with amphotericin B, just remember the keyword pores. With polymyxin, just remember the keyword acting as a detergent. And with daptomycin, just remember the keyword charge barrier, that is going to alter the charge barrier, or you can say the ion concentration across the cell membrane, and thus cause ultimately the leakage of cellular components. Got it? Okay. One very important point about these polymyxins is that they are used as a part of the Thayer-Martin agar that is used for culturing Neisseria. So you basically know that Neisseria is very hardy organism and it's very difficult to grow in cultures. So it needs a very special medium. And this is a very important point about this medium, that this medium basically uses 3 components, right? So it's called Thayer-Martin, or another name for this medium is VPN, right? And VPN, the V stands for vancomycin, the P stands for polymyxin, and N stands for nystatin. Right? And it might come to your mind like, come on, why are you using these 3 antimicrobials, drugs that basically kill out the organisms? Why are we actually using them to grow the Neisseria, right? So basic reason that they can ask you again, that we use Thayer-Martin medium to grow Neisseria. So what is the reason that we used Vanco? The reason that we use Vanco is that it is basically going to eliminate the gram positives and not let them grow. What polymyxins are going to do is that they are going to eliminate the gram negatives, right? They're going to eliminate the gram negatives other than Neisseria. They're going to let Neisseria gonorrhea or meningitis grow, but other than that, all the other gram negatives, for example, like Pseudomonas, they are going to be eliminated, right? So that's why they are effective against other gram negatives. And nystatin, of course, you know, nystatin is an antifungal, so it's basically going to eliminate the fungi. So in this way, all the gram positives, the gram negatives other than Neisseria and the fungi are now eliminated, and the only thing that can grow on this medium is now a gram-negative diplococci, which are Neisseria gonorrhea and meningitis. So you must know that which are the gram-negative organisms that are susceptible to polymyxins, that is, they are going to be killed by the polymyxins. Those are other gram-negatives such as Pseudomonas. But which are the ones which are not basically killed by the polymyxins? And they are the gram-negative diplococci such as Neisseria gonorrhea and meningitis, right? So they are it basically allows them to grow and doesn't kill them off. Okay. So now again, the scenario can go like this, that there was a patient who developed this septicemia with multi-drug resistant gram negatives, for example Pseudomonas, right? And you started him on a very hard-hitting drug since it was multi-drug resistant, right? And now it immediately comes to mind that it might be polymyxins. How do we confirm it? They say that after starting the drug, the patient started developing this stock and glove pattern of neuropathy in his hands and feet, right? Glove and stocking pattern. Or they can say the patient started developing hearing difficulties or ringing and tinnitus in the ears, right? So then it comes to your mind, so that is basically neuro or ototoxicity that is basically being caused by polymyxin. And again, making the integration over here, what other drug, they can say that what other drug is from amongst these class of drugs can cause a similar adverse effect. And then it might be, if it's causing neurotoxicity, another similar drug can be cisplatin. It's a platinum-based agent. It's basically a drug that is used for tumor and cancer. It's an anti-cancer drug. And so cisplatin can also cause neurotoxicity just like polymyxins. And similarly, they can ask you that what other drug can cause ototoxicity, right? So you must know that the significant drugs that can cause ototoxicity for your step examination in USMLEs is loop diuretics along with aminoglycosides, right? So this concludes our discussion on polymyxins. Let's move on to sulfonamides. And just remember, they are basically the majority of drugs over here are going to be DNA synthase inhibitors, but the polymyxin is an exception, you can say. This was a detergent on the cell membrane and not a DNA synthase inhibitor. Now we are going to begin the discussion on DNA synthase inhibitors. Okay, so for this, first of all, in order to memorize all these drugs, you must you can take a screenshot of this page and commit this to memory. There are basically 2 steps, and in 2 steps there are 3 ingredients that we are going to use and play around with, and then we are going to remember, on which step which drugs are inhibiting, right? So you have to remember that there are 3 basic steps in the synthesis of folic acid that will then be utilized for DNA synthesis. First step is from P, second step is with D, and third step is with T. So PDT, you can remember it with any way, but I just like to remember it with this 3 words, that Pacific Daylight Time, right? So PDT. Okay, so first P stands for PABA. This is the first ingredient that we are going to use, para-aminobenzoic acid. The second step is with the D, which can be dihydrotaurate, or you can simplify and just remember dihydrofolic acid, DHF, right? And the third step with the time is T, which is tetrahydrofolate, right? So these are the 3 ingredients that are being shuttled, and in between these 3 ingredients we have 2 enzymes. The first enzyme is DS, which I remember it DS short for the disease, right? So dihydrotaurate synthase. And then From dihydrofolate to tetrahydrofolate, I remember it with the mnemonic DR, doctor, right? Dihydrofolate reductase, right? So the first step from PABA to DHF, the enzyme that we have is DS with the mnemonic disease, dihydrotoluate synthase. And then after from DHF to THF, the enzyme that we have is DR, the doctor enzyme, which is dihydrofolate reductase. And now we have to connect this and remember that which are the drugs which are inhibiting DNA synthesis by acting on dihydrotoluate synthase, and those are the DS drugs. So the enzyme is also DS, dihydrotoluate synthase, and then the drugs that are acting on this particular step from PABA to dihydrotoluate are also DS. So D for dapsone and S for sulfonamides. Okay, so now you can remember it easily. Disease, DS dihydrotoluate synthase, and DS dapsone and sulfonamides. Next off, we have the next step, dihydrofolate to tetrahydrofolate. And the enzyme that we had over here, it was dihydrofolate reductase, right? The DR doctor enzyme. Now, how are we going to memorize the drugs that are related to the doctor? So you can remember it with a mnemonic of Tampa, Florida. So Tampa, Florida basically has lots of doctors, right? So TMP is for, T is for trimethoprim, M is for methotrexate, and P is for pyrimethamine. And other than that, you can also remember that TMP is the short form for trimethoprim as well, right? So trimethoprim is used by a lot of doctors, right? So T is for trimethoprim, M is for methotrexate, and P is for pyrimethamine. And all of these drugs are acting where? All of these drugs are basically acting on dihydrofolate reductase, the doctor. So TMP, doctor, that's your mnemonic for the second step from dihydrofolate to tetrahydrofolate blockage, right? So they can ask you basically for the specific enzymes as well. But more often than not, they don't ask you for the specific enzymes, and they just want you to know that these drugs, the disease and the TMP drugs, dapsone, sulfonamides, T for trimethoprim, M for methotrexate, and P for pyrimethamine, the main mechanism of action of these drugs is blockage of folic acid synthesis and ultimately blockage of DNA synthesis, right? Okay, so this was the general mechanism of action. Now let's go through the way the question is going to be framed in the examination, that they're basically going to give you some sort of a patient, and the patient can have what? So the patient can have pneumocystis jirovecii pneumonia. So the patient is basically an immunocompromised. He's having signs and symptoms of pneumonia, fever, chills, and you find out ground glass appearance on your chest x-ray. And after that, they can ask you that, okay, what is the drug that could have been used for prophylaxis, or what is the drug that we're going to use for treatment? And then they can ask you the mechanism of action for that drug. And because you have memorized this chart, you will be able to answer that the drug we are going to use is going to be trimethoprim sulfamethoxazole. For trimethoprim, which is blocking dihydrofolate reductase, and sulfamethoxazole, which is a sulfonamide, and that will block the dihydrotoluate synthesis, right? So in this way, you can answer this question of PJP, right? And similarly, they can have another patient who is presenting to you with similar UTI, and then you have to know that you can use TMP SMX for it, right? And similarly, MRSA skin infections, remember we did this in our previous parts of antimicrobials, that since Vanco has very poor skin penetration, therefore we cannot use it for MRSA skin infections, and therefore we can use TMP SMX. Similarly, they can ask you that the patient is basically having toxoplasmosis, and what's the drug that could have been used for the prophylaxis, then that would be TMP SMX. However, if they ask you that what's the treatment of toxoplasmosis, then that would not be like TMP SMX. Rather, the treatment would be sulfadiazine pyrimethamine. Of course, like sulfadiazine is still a sulfur drug, and that will still block the DNA and the folic acid synthesis, but the name is slightly different. So you need to remember this. This is a very important point for you, that there are two diseases. One is PJP, pneumocystis jirovecii pneumonia, and one is toxo. Right? And there are two limbs for each. One can be the PPX shield, which is the prevention, and one is the treatment. So for our PJP pneumonia, the PPX along with the treatment are both the same, which is TMP SMX, right? They're both the same. Whereas if they ask you about toxo and they ask you for the PPX, the pre-exposure like prophylaxis or the prevention is still the same, TMP SMX, but the treatment is slightly different. This one is the odd one out, and that is pyrimethamine sulfadiazine, right? So just remember this. This is very important for your examination, right? Pyrimethamine and sulfadiazine. Okay. Sulfadiazine, right. Okay. So let's moving on. similarly, just like they gave these scenarios to you, remember these 4 things: the PJP pneumonia, simple UTIs, MRSA skin infection, along with toxoplasmosis. And if you want to remember it in the form of like a drawing, you can also remember it like beginning from the brain, toxoplasmosis, right? And then coming to the lungs with the PJP pneumonia, then coming down to the bladder and UTIs, and then coming to the skin with the MRSA skin infection, right? So they can say that there was a patient who had toxoplasmosis, or he has PJP pneumonia, or he had a simple UTI, or he had a MRSA skin infection, right? And now after starting this drug, what has started to happen with this patient? And what has started to happen with this patient? And now you have to tell the mechanism for this particular reaction that is taking place. So there are, again, we are going to go through the step ladder pattern. There, from the least you can say severe to the most severe, there are 4 types of things that can happen in these 4 types of diseases. These 4 types of diseases for which you are using trimethoprim sulfamethoxazole, toxoplasmosis, or PJP pneumonia, or simple UTI, or this MRSA skin infection, right? And now there are 4 types of things for these 4 diseases. These are the 4 types of things once you start TMPSMX that can happen. There is type 1 hypersensitivity, then there's type 3 hypersensitivity, then there's type 4 hypersensitivity, and then there is membranous glomerulonephritis. Of course, they're not going to say type 1 hypersensitivity, right? So you need to know the clinical presentation. So let's go through the clinical presentation one by one, and then let's connect it back that what is the type of hypersensitivity, because again, our friends at the NBME, they are known to give the scenarios like this, that they will give you the adverse effect and they will ask you the mechanism of how this adverse effect developed, right? So for that, you need to be very clear upon what the reaction is, and then what type of hypersensitivity it is, and what is the mechanism behind this type of hypersensitivity, right? So the patient had PJP, and now after starting TMPSMX, he has developed a maculopapular measles-like rash, right? Which is also, it can also be called a morbilliform rash, right? Or they can say that after starting this drug, the TMPSMX for PJP, he has developed some skin lesions that have multiple shapes. So erythema multiforme. Multiforme basically means varied shapes, right? So now they are going to, after telling you that the patient has developed this, they can ask you, okay, what's the type of hypersensitivity? You know, the type of hypersensitivity is just a type 1 hypersensitivity. Or they can ask you the mechanism for hypersensitivity, that this is basically an IgE cross-linking on the mast cells. Or they can ask you what's the type of drug, it's a sulfa drug. Or they can ask you the mechanism of action of the drug, which is DNA sensitive folate inhibitor, right? Okay, so this was something that developed immediately. You immediately started TMPSMX, and now the patient has maculopapular rash, measles-like rash, or has skin lesion with multiple shapes. Or they can ask you that after 3 to 5 days, so you started TMPSMX, 3 to 5 days have passed after the drug administration, and now the patient has developed either arthritis, he is having joint pains, or the patient is having, again, a type of reaction that is localized to the skin at the injection site, right? So the arthritis or the erythema nodosum, they can basically serum sickness, or arthritis reaction is basically which is localized. So arthritis reaction is a localized reaction, right? Local reaction, whereas serum sickness is begins with the S, so it is a systemic reaction, right? So developing arthritis or erythema nodosum, which we will see, it is a form of paniculitis or a form of, you can say, bumps in the subcutaneous fat that are known to develop on the shins. Of course, they can be on the arms as well, but known to develop on the shins, right? So this systemic reaction with the serum sickness of either arthritis or erythema nodosum, or this localized reaction where just at the injection site where you gave him trimethoprim sulfamethoxazole, this patient is developing the skin lesion, right? So this is basically type 3 hypersensitivity, and they can ask you the mechanism that this is due to immune complex reaction. So remember, serum sickness or arthritis reaction, a localized serum reaction at the injection site, whereas serum sickness which can present as arthritis or erythema nodosum. Erythema nodosum basically means an inflammation of the subcutaneous fat, that is paniculitis, and the type of hypersensitivity is type 3, and the mechanism is immune complex deposition. And then, so this is slightly like more severe as compared to the simple rash that the patient developed immediately, right? This is after 3 to 5 days. Now, in contrast to this, there can be something really more serious that can develop, of course, like at that particular time or after some days. And in that situation, the patient is actually beginning to slough off the skin. The skin is denuding, right? It's falling off. And the patient has developed diffuse bullae, similar to that of pemphigus vulgaris, and has a positive Nichols sign, in which the the skin is just falling off and peeling, right? So in this situation, how you're going to like figure out what is the type of reaction? If it is covering less than 30% of the body surface area, then this is known as Stevens-Johnson syndrome. Whereas if it is covering more than 30% of the body surface area, then this is toxic epidermal necrolysis, right? And both of these are, they can ask you for the type of hypersensitivity, that this is type 4 hypersensitivity, and then they can ask you for the mechanism, this is basically T cell response. So remember, a simple morbilliform rash, a maculopapular rash, measles-like rash, or skin lesion with multiple shapes, after starting TMP-SMX for PJP or toxoplasmosis or UTI or MRSA skin infection, then the type of hypersensitivity is type 1 and the mechanism is IgE cross-linking. If the patient develops arthritis or erythema nodosum, which is basically serum sickness, or has a localized skin reaction at the injection site, this is a serosickness or arthros reaction, which is type 3 hypersensitivity due to immune complex deposition, right? And then if the patient is having extensive skin necrosis and sloughing off, like positive Nikolsky, or diffuse bullae formation, but if it is less than 30%, this is Stevens-Johnson syndrome. If it is greater than 30% of body surface area, this is toxic epidermal necrolysis. And if they ask you for the type of hypersensitivity, it is type 4 hypersensitivity, and the mechanism is basically T cell response, right? And of course, if they ask you for the next step in management for the step 2, you are going to treat both the SJS and TEN in the burns unit. But the use of steroids and IVIG is still controversial. But one thing is for sure in the next steps, that you will admit this patient to the burns unit. Of course, his skin is sloughing off, right? So it's like a burn. He's going to lose his body water and can become dehydrated and die and develop infection as well, right? Okay, so these were the 3, you can say, the skin reactions or the hypersensitivity. Now there is another thing that can develop after TMP-SMX use, that they can say that the patient has basically, like after using TMP-SMX, is he's having deterioration of the renal function, right? So he's developing, he's becoming puffy, the classical 4 signs and symptoms of nephrotic syndrome, that he's becoming puffy, he has proteinuria, he has hypoalbuminemia, right? And he may or might not have deteriorating renal function. And once you do electron microscopy, you see spike and dome appearance of subepithelial immunoglobulin and complement deposition, right? So you must know that this is basically membranous glomerulonephritis, which is being caused by TMP-SMX, right? And you must differentiate, like we were doing these integrations, you must differentiate this simple nephrotic syndrome caused due to TMP-SMX by acute tubular necrosis. So in this case of nephrotic syndrome, the maximum they can say is that fatty casts or something like hyaline casts are coming in the urine, nothing more than fatty or hyaline casts. But if they say that the patient was again like started on a drug such as for endocarditis, like some drug for endocarditis, and now the patient has muddy, dark, dirty brown granular casts. So these muddy, dirty brown granular casts actually connect to ATN, and the ATN is caused by aminoglycosides such as gentamicin or amikacin, right? But in this situation, like the TMP-SMX situation, we basically had nephrotic syndrome, which you can have fatty casts or hyaline casts at most, and greater than 3.5 grams per day of proteinuria and hypoalbuminemia, and spike and dome appearance of subepithelial immunoglobulin and complement deposition. So this is membranous glomerulonephritis, and you have to differentiate the two. What is being caused by aminoglycosides and what is being caused by TMP-SMX. So I guess we have covered a lot over here, and we are going to pause over here and continue in the next video. So just a quick recap, we covered polymyxins such as colistin, which are basically causing the leakage from the cell membrane of the contents, and we covered all the sulfonamides, which is TMP-SMX, and we are going to study dapsone, pyrimethamine, and methotrexate in the next video. But up until now, be sure that you should be very clear on these like steps. What's the step number 1? What's step number 2? What's the enzyme for step 1? Which are the drugs acting on step 1? What's the enzyme for step 2? And what are the drugs acting on step 2? And just one thing that I forgot to, like the integration that I forgot to make previously, is what is another drug that is notable to cause SJS and toxic epidermal necrolysis, that they can give you a scenario in which a patient who has basically epilepsy and he was started on an anti-epileptic. So one drug that is known to like turn up on your NBS CME and the USMLE examination is that the antiepileptic that is known to cause SJS and 10 is known as lamotrigine, right? And once we cover antiepileptics, we are going to go through its mechanism of action in detail as well. So I'll see you in the next video. If you like this content, please like, share, and subscribe. And don't forget to tell me in the comments what you like about these videos and what other videos would you like to see. And I'll see you in the next video. Till that time, happy studying.